So thank you everyone for attending the fourth seminar of the Gilbrea seminar series. And as I think most of you have been here before, so you know that the idea is to have an exchange amongst researchers, grad students, faculty, community members, older people. And this year we're exploring visual methods and knowledge exchange. So talking a little bit about how to move research in and across kind of practice contexts and into different audiences. So today we're thrilled to have Alisa Grigorovich with us, and she's going to present on enhancing access to quality long-term care services for older LGBTQ persons. She's at the moment a CIHR postdoctoral fellow at the Toronto Rehabilitation Institute, and her work is funded by CIHR. Funded by CIHR. She's going to present for about 40 minutes, and then we have a discussion following that. All right? So welcome, Alisa.
Thanks so much, Linda, for that really kind introduction, and for inviting me to speak here today. I'm going to sit, if that's cool with people, just because there's not many over here. And just be easier with the notes, too. So this is my first visit to McMaster, and I'm really excited that it's to join the ranks of other illustrious aging scholars that have spoken before me at the Career Series. And my talk today will focus on the long-term care experiences and needs of older lesbian, gay, bisexual, trans, and queer people, or LGBTQ people for short. And more specifically, I'm going to talk about home care services. So this topic is a key area of concern in my research program that broadly focuses on stigma and violence in healthcare and its implications for mental health and resilience of marginalized older adults and carers. In recognition of the importance of not only identifying but also challenging stigma, I'm engaged in the development and evaluations of arts-based initiatives for knowledge translation and for the purpose of transforming care. Just to give you a brief overview, so I'll share with you examples from my research as well as the research of others to really demonstrate that there's a critical need to develop education and training initiatives to enhance the capacity of home care providers to respectfully and appropriately care for older LGBTQ adults. In particular, given the stigma associated with later life sexualities and LGBTQ identities and intimacies, there's a need to engage in innovative methods for knowledge translation and education. In arts-based methods, and in particular those that engage audiences visually, such as film and animation, can be particularly powerful in that regard. So I'll finish by presenting an example of one such initiative that I'm co-developing with colleagues called Out at Home. So despite advances in civil rights and the redefinition of the family in Western context, LGBTQ people continue to experience marked health inequalities, including increased rates of certain cancers, infections, and chronic diseases. And a key contributor of these health inequities is the stigma that is associated with sexual minority identity and gender nonconformity. So stigma is a complex social process that involves prejudice and discrimination, and you can think of it as existing across three interlocking levels. Individual stigma, such as concealment of your identity or the feeling of fear, interpersonal stigma, and structural, which is policies and cultural norms. So examples of stigma in healthcare, including interpersonal and structural stigma, include things like heteronormative practices and policies, the lack of professional education regarding LGBTQ health needs and experiences, as well as providers' homophobic and transphobic remarks and actions. This stigma negatively affects LGBTQ people's mental health and well-being, erodes their trust in care providers, and negatively influences their future health-seeking behaviors. So I'm going to show you a brief video so you can get a better sense of what this stigma looks like and its implications for access and equity.
A few years ago, I was diagnosed with polycystic ovary syndrome, and the doctors who treated me wanted to treat me as if I was a cisgendered woman who wanted to have kids, and didn't really take into account that that's not necessarily the way I identified or what I wanted.
Early on, after coming out, I had a negative experience actually during my first pap smear. In the middle of it, started asking me questions about my sexuality, and then giving me quite a lecture about morals and about what was right and wrong to do with sex, and about letting down my parents, all in the middle of the procedure, which was a really sort of traumatic experience.
Just after I was received my positive diagnosis for HIV, I sought the services of a clinic in Melbourne. Basically, the assumption was made that I was just looking for a good night, and basically made the choice of having unprotected sex, when actually the case was I was sexually assaulted, and that's how I contracted HIV.
When I came out, I had a lot of issues with my family and them accepting that, which led to a few years being estranged with my mother in particular. And to rebuild that relationship, we had a few mediated sessions with a therapist, and those sessions became about how I'd left my mother in the dark and how I'd done wrong by her. I ended up in an adult psychiatric ward where the doctors all refused to acknowledge me as trans and used the wrong pronouns, like, deliberately.
I've never had a good experience in healthcare.
It made me feel like I couldn't trust doctors. It made me feel like I had to very much bury who I am and just pretend to be normal, I guess. This experience made me feel really vulnerable and not safe in my vulnerability. Yeah.
This experience made me feel dehumanized. It made me feel like I wasn't worth as much as other patients.
I've had one really good experience with a neurologist that I saw. She noticed that I'd ticked Mr. on the box, but my doctor had put the referral as female. And so she actually spoke to me sort of briefly about that and just asked what pronouns I prefer, and when she then had to write a letter again, she checked what I wanted to actually have on it, and that was fantastic.
I had a good experience with a GP who wasn't fazed in any way, you know, didn't blink, didn't act uncomfortable or awkward as soon as I mentioned my partner. And from the beginning, I felt that she understood that I was in a same-sex relationship, that it wasn't particularly relevant to the issue that I'd come there for, but if it did come up, it was something that could come up very easily and comfortably.
Come across a dental practice and they're really caring. They know I have HIV, and they're just very gentle and very considerate.
My message to healthcare providers would be to take the time to really learn about and become comfortable around issues relating to sexual diversity and gender diversity.
If it's out there and we know that people are actually investigating and finding the information, they actually understand, it shows that understanding of that, we can actually stop being so prejudiced ourselves and maybe try to find that help.
LGBTI people do go through more issues because we do have to deal with mental health at a higher rate than our heterosexual counterparts.
My message to healthcare providers would be just listen to your patients. If they say that they're trans or they prefer certain pronouns, it doesn't really affect you as a doctor, just use the pronouns they ask.
It starts with just a dialogue, communicating, and not expecting it to be listed on a piece of paper. It's very important that we have a communication that's one-to-one and that someone is actually listening to what we're saying.
So this video shows the experiences of people in Australia, but empirical research shows that the same challenges are faced by LGBTQ people in Canada and North America broadly. And As the video shows, stigma is really a critical barrier to quality care in institutional healthcare spaces. And there's plenty of evidence already to guide education and policy for how to challenge the stigma in this sector. And I love this video because it's a brilliant example of how arts-based methods can actually be used to challenge that stigma. However, little research has been conducted on stigma in the context of home care services and other long-term care services. And this is problematic as we cannot assume that what we know about stigma in institutional care spaces can just be extended to reform home care services. Home care happens in isolation in private homes with little professional oversight or support. Care users have limited opportunity or choice in terms of identifying competent providers or modifying the quality of their care. And the most common type of care provided is very intimate and relational in nature. It involves positive human contact and direct help with basic activities of daily living. So, more than that, we actually know very little about the experiences of older LGBTQ people who access healthcare, and these are more likely to need home care than of younger adults. And the current cohort of older LGBTQ people is very unique in that their life stories include living for decades where homosexuality was criminalized, subject to overt medical intervention, and open moral condemnation of same-sex relationships and intimacies. So while this arguably has gotten a lot better, this history casts a long shadow and continues to influence the care experiences of older LGBTQ people. And it's just one example of this. Large-scale surveys for North America consistently demonstrate that older LGBTQ adults, especially those over the age of 65, are much less likely to disclose their sexual or gender identity to healthcare providers than younger LGBTQ adults. And many older adults continue to live double lives where only those closest to them know their sexual or gender identity. So I wanted to just give you a brief glimpse into this cohort and their experiences. And to do that, I'm going to show you a video clip from an oral history project with older LGBTQ adults from Los Angeles. And again, much of what they share about their experiences of growing up LGBTQ in the States is very similar to the experience of growing this way in Canada.
I've always been comfortable with the very fact that I'm different. I'm different. I'm a different person. And in those days, let me tell you, it took a lot to be homosexual because you don't know what the cops are going to do. You don't know that people on the street will, beat you up or something like this. And I'm not exactly the most masculine person in the world.
Growing up, I knew that there was something different about me, but I really didn't know what it was. I was a late bloomer as far as being sexually active. In fact, I thought growing up that I was the only person who was like that.
I absolutely thought there was nobody else in the world like me. I thought I was the only gay person in the world. I was ready to live a life as the one person. I went to the dictionary and said, what is it? And I looked up homosexuality, and it said it's a phase that one passes through.
And I called my mother and I said, can I come to dinner Tuesday night? I have something I want to talk to you about. And she said, what? And I said, I'll tell you Tuesday. Oh my God, you have some girl in trouble? I said, no mom, no girls involved.
My mother sat me down one time and says, whatever you do while you're out there running around, don't you ever come home and tell me what you did. No, that shut everything off. No communication, no nothing about my life. That there was never any question. I could have boyfriends and things like that, but it was never questioned, never talked about.
So my mother got the letter from Lucky that I was supposed to get, and she was crying and very upset and telling me I don't want my daughter to be a lesbian, and she didn't use that word, but So then my father got a hold of me, and he started talking to me, and he said, do you want to go see a therapist, a shrink, whatever you want? And I said, no, I am who I am, and I'm fine, don't worry about it. And he said, well, you're my daughter, and no matter who you are or how you are, I'll always love you.
I wrote her a note saying that this is a subject we've never talked about, but I wanted you to know that I'm a lesbian, and Barbara and I have a very good relationship, and we wanted you to be aware of this. And she called back shortly and just said, we love you. But I was glad I had done that. I didn't come out to my parents, my mother especially, because I thought she would blame herself.
She was very hostile to the idea of being gay.
That's not for me. So, absolutely not me.
And I didn't have that attitude because I'm gay, and I felt that's all. I have no choice. I am gay. When I told her how I felt, and she told me she felt something too, but she was afraid of the idea of being gay. I tried to talk her into it, telling her about the ancient Greeks, but whatever good that did.
And I couldn't even use the word gay because it sounded so frivolous. So I said, I'm homosexual. And my father said, what? And I repeated it, and he looked at my mother immediately and said, must be your side of the family. All the men on my side of the family were men. And my mother immediately snapped back and she said, oh, really? What about your cousin Sydney?
If she didn't know, she could deny it. If she knew, she could have defended me. But back in those days, it was common knowledge that you could be arrested for being gay.
I was very secretive. I found out that I was living in a closet. It was in New York. At that time, it was illegal to be gay. It was considered a mental disease to be gay.
You had no civil rights, you had no real legal rights. Nothing was anything but that you were a criminal in those earlier days. So the police would come to people's homes, they'd send the state police and drag them out and take them off to jail and so on.
I remember specifically not wanting to be seen with anybody who was, I hate even to use that term anymore, to put it in that sense, but who was a little bit more effeminate or, I hate that term straight appearing, but that's what I was looking for. Somebody you couldn't tell. The fear was that somebody would know who I was. It didn't occur to me that if I'm out with 14 straight people, they'll think I'm straight, but if I'm with one gay person, they'll think I'm gay. Of course they would know.
I was like this. We couldn't do anything. You couldn't dance in a bar. You couldn't be in a bar. You couldn't touch anybody. God, you had to be closeted. I remember with the first woman I ever was with, I was 21 years old, going to a grocery store, and a guy came up to me and he said, I know what you need, baby. I mean, just sickening.
I had to live two lives for so much of my life. I was Mr. Malone during the week, and I was Jimmy on the weekend. I can't come out and flaunt anything. My personality doesn't allow it because I'm so trained to be two people. I don't have to live two lives now, but I don't know how to live any other way. No.
So the first step towards ensuring that home care services meet the needs of older LGBTQ adults requires that we begin with more research into their experiences. So to begin to address this gap, in my doctoral research, I interviewed 16 older lesbian and bisexual women in Ontario who accessed home care services. My aim was to understand their access to care, unmet needs, and their experiences with providers. And I have a more detailed description of the methods that I used in this research that's been published elsewhere, and I can speak more details about this later if you guys are interested. And there was a number of findings that came out of that study, but here I just want to highlight a few key findings that are relevant to understanding how stigma is a barrier to quality care. I found that as a result of fears and negative past experiences with healthcare providers and with others, most participants did not typically disclose their sexuality to home care providers or choose to come out to them. They anticipated that home care providers would assume that they were heterosexual unless they explicitly disclosed otherwise. And while this concealment was protective, the need to be constantly on guard and monitor providers' reactions was very stressful. And it also exacerbated the vulnerability that they already felt as a result of relying on strangers for care. So for example, one participant explained this constant feeling of being potentially vulnerable to harm this way. So she said, I always think about, will they personally harm me? Will they insult me? Like if they throw me on the floor or trip me, I'm there for the day. If they insult me because I'm a woman, or I tell them that I'm a lesbian or whatever, then I'm hurt, I'm upset. Then I'm left, what do I do about that person? Do I tell my partner? And I'm home alone, she's not here, so here's what I'm risking. For those who did come out, this was to providers who had been known for an extended period of time and expected to know them for longer. And this was a gradual process of complex decision-making during which they gauged their care provider's reaction. So one participant described it in this way. She said, I gauged the situation to see how I come out, because this woman is taking care of me on a really intimate basis. I think it was in 2008, a year after I began receiving care, that I finally said to her, do you realize that I'm a lesbian? But I'm not out to any of the fill-in replacement home care providers. So similarly, another woman said, I don't blurt out, I'm gay, but I say to the care providers, so this is my wife, and I just sort of kind of ease in my wife, and hopefully she'll get it. As many didn't typically disclose, and providers indeed assumed that they were heterosexual, most did not report any overt examples of discrimination, such as the kind that we just heard about from that video. However, they did describe less overt homophobia and heterosexism, such as providers questioning or denying the validity of their romantic and legal relationships. So as one example, one participant said, but the second home care nurse was homophobic. She asked me if I was married, and I said, yes, that's my wife. And she said, your wife? And I said, yes, we're gay. And then she said, oh, well. She got really, I don't know if I agree with that. At times, these type of more subtle negative reactions, as well as others such as indifference or just a lack of engagement after the provider found out, were also difficult to recognize as prejudice or stigma. This one participant talked about it, and she said, I kept thinking, the home care providers were not saying anything derogatory, but just by their not asking about my family members, for me there was something missing. I never got, how is your spouse? That's the big thing that I noticed, it's so subtle. Like I really like bigotry when they slap you right in the face and they go, listen, you friggin' queer, you know you're being done in. It's the subtle stuff that's left out that's so horrendous, and sometimes we miss it ourselves, and other people don't even know they're doing it, and how offensive it can be if we're smart enough to get it. One of my participants did though also report that she was refused care due to her gender expression. So she described one provider who came and said, so she's got a Bible and she's telling me she's not washing my clothes. And I said, oh, did I hear you correctly? You're not washing my clothes? Can you tell me why? Because I don't wash men's clothes. And I said, so you think that my clothes belong to a man? I don't wash men's clothes. Well, there's no men living here. None of the clothes are worn by a man. And the provider just said, I'm not washing men's clothes. That's not what I get paid for. My findings also suggest that older lesbian or bisexual women may have really low expectations of good care and be hesitant to complain about unprofessional care that they received. So for example, one participant stated that as a result of her care provider's positive attitude towards learning about her sexual identity, she didn't care that she dropped her in the tub. My caregiver was quite open. She said, I'm getting used to this. She was young, laughing, having a great time. She said, oh, you're really a lesbian? And I thought, no, I'm faking it, lady. I don't care if she dropped me, 20 points for that one. 20 points for wanting to know what a lesbian is, how we live. And she did it in such a way that it wasn't offensive. Despite this, some participants did also tell me that they discontinued home care prematurely as a result of negative experience, or their fear of encountering homophobia if they continued. As one participant who experienced homophobia while she was hospitalized and then later discontinued home care explained, "I'm afraid I'd get that kind of person again. That would be awful. At least while at the hospital I was able to move around. If I wasn't able to, I would not want to be at the physical mercy of somebody who did not respect me." I felt that way at the hospital with that nurse. And I was pretty sick when getting home care. I was a lot sicker than I realized at the time. But I just pushed myself. I didn't realize how much I pushed myself. But to be weak around that kind of person would just be devastating. It would be physically vulnerable and not safe. I also asked my participants to tell me what could improve the quality of home care for them. And many emphasized the need for mandatory sexual and gender diversity training for home care providers and for organizations. They explained that knowing that their providers had had this training would lessen their ongoing worry about experiencing homophobia for them. As one participant explained it this way, "Home care is so intimate, and you depend upon that person, and that person can be mean to you, especially if you're an older person and you're still out. And to me, it's a matter of who has the power, and they can always use it against you." They also stressed that quality of care was supported when their providers explicitly acknowledged, recognized, and affirmed their identities and relationships, and actively strove to reduce their fears of being mistreated. So participants wanted providers to demonstrate that they know a little bit of what it's like to be lesbian or gay by being aware and open to the possibility of sexual and gender diversity. So for example, in the language they used with them, or in the assumptions they made about their partners or their families. And at minimum, they wanted them to provide care without expressing complaint, discomfort, or judgment about LGBTQ people. However, they wanted more than just to make sure that providers weren't outwardly homophobic. They wanted providers to demonstrate being at ease with providing care to a lesbian or bisexual woman by acknowledging their family and their life experiences. So one of my participants explained it in this way: "I want someone that I'm comfortable with and someone that's going to be comfortable in my home because I live in a lesbian household. If I'm calling an agency and I need some home care, it should be within my rights to say I want someone who's comfortable working in a household when I'm living with another woman and we're lesbian. I mean, it's not a sexual issue. This is just who my household is, and this is who my support person is." So my findings demonstrate that invisibility and stigma is a key barrier to quality home care. Although my research focused on older women, my findings regarding stigma and the importance of providers affirming attitudes are very similar to what others have found with research with older bisexual and gay men. I do want to, however, briefly touch on the experiences of older trans people to demonstrate some unique considerations for this population. So first, trans older adults are as diverse as younger ones in terms of their gender identities, gender expressions, and sexual orientation. Like LGBTQ people, older trans people hold many fears regarding mistreatment and discrimination from home care providers. And much of this fear is rooted in historical and contemporary experiences of mistreatment in institutional healthcare spaces. A particular point of concern for trans people, however, is being subject to discrimination based on our history of transgender or gender nonconformity if this is revealed to providers without their consent or as a result of their documentation or their embodied presentation. While transitioning is not a uniform experience and not all trans individuals choose to medically transition through surgery or hormones, many older trans adults have kept their gender identities hidden for decades and have opted to transition much later in life than younger trans people do today. For financial and other reasons, they may not have changed their official documentation or engaged in medical transition at all. And even those that have continue to hold fears of being outed or not receiving appropriate care. So for example, consider this from a trans bisexual person speaking about their concern regarding home care. I'm not so much concerned because of my sexuality, but definitely with my gender history and the state of my body. I worry that I'll become incapacitated and not be able to communicate my history as a trans person, medical or surgical history before requiring care. I worry that caregivers will not be experienced in dealing with trans bodies and health issues, and that I'll at best not get the care that I need, and at worst be ridiculed, mocked, or ignored because of the state of my body. So trans older adults may be even more vulnerable to mistreatment and stigma when accessing home care. Research with home care providers suggests that there continues to be a knowledge gap between empirical research on the importance of affirmative and respectful care for well-being of older LGBTQ adults and providers' competencies in this area. While there's growing attention to later life sexuality and LGBTQ health disparities in empirical literature, the formal curriculum of providers rarely includes content on sexuality or gender. And what it does, it primarily focuses on the dangers of sexually transmitted infections or pregnancy and different risk factors for diseases. This type of technical training is important, but it doesn't address the complex nature of sexuality and gender, and it's not sufficient for challenging personal negative attitudes regarding sexual or gender diversity that may impede good care. This is, of course, compounded by the invisibility and the stereotypes associated with later life sexuality and gender expression of older and disabled people. So it's really not surprising that providers across all care settings report knowing little about the sexual or gender identities of their older clients, and often believe that they've never cared for an LGBTQ person. Moreover, and sometimes I actually think this is worse, providers may not even believe that knowing this about their clients is as important because they think this kind of information is private, or they think it doesn't meaningfully impact their care. So although regulated home care providers such as nurses and social workers have a lot more access to professional education opportunities than the most common type of home care provider, which are care aides or personal support workers, all providers receive little overt instruction about LGBTQ health or issues. So just to give you a really glaring example of this, in 2015, a survey was done with 379 different kinds of home care providers, and 90% of those surveyed said they have never been exposed to any LGBTQ-specific continuing education opportunities while being employed in this sector. So there's also very little training material that specifically concerns older LGBTQ people, and even less that is targeted towards providers in home care. When training does happen, these are usually one-off sessions, and the content covered is pretty basic, such as definitions of basic terms, and it often uses a passive form of information sharing, such as a lecture and slides, rather than the development of specific practice skills. This is problematic, as we know from health professions education literature more broadly, that to implement meaningful practice change, education must be tailored to the audience, and that education must invite them to share of themselves and to connect emotionally with the perspective of those who they view as essentially different from themselves. Further, education must support their ability to imagine how they may act differently to affect change. The danger of doing one-off didactic types of training sessions that emphasize difference and that are overly disease-focused is that they can actually reinforce rather than challenge the bias or stigma that already exists towards LGBTQ people. So it's thus key that educational initiatives facilitate both empathy and critical self-reflection by providers about their own understandings, assumptions, and practices. So my own experiences with creating research-based dramas for education demonstrates that these and other types of arts-based educational initiatives are particularly effective for challenging stigma and for affecting practice change. In particular, the use of dramatization and narrative in the context of creating a play, animation, or a film is particularly powerful, as these visual mediums support embodied and effective learning over and above solely enhancing cognitive understanding of a particular topic. So I was asked by Amanda, I put some examples of my collaborative work in this area, and I'm happy to speak to you guys about it as well afterwards. Just briefly, I've done an evaluation of the impact of a research-based play called Craft, New Light of Dementia, that we found reduces stigma associated with dementia by decreasing providers and carers' prejudice, fostering critical reflection, and a commitment to individual and collective action to address stigma. We've also done an evaluation of a research-based film called Fit for Dialysis, and it's a really brief 15-minute film, but we found that it increases awareness of the benefits of exercise for older hemodialysis patients. It ameliorated fears of adverse outcomes. And it actually motivated people to engage in exercise and to encourage exercise. So it was pretty powerful. And lastly, I've also co-developed some research-based animated videos. And one example was a video we've done in HL on transdisciplinary research. So what has been most interesting for my collaborative research into this type of work is the consistent finding that what makes these initiatives so effective is their combination of a research base and the aesthetics of the art form. So the research base is really key for ensuring audiences' sense of relevance and identification with the educational content. But it's the aesthetics of the art form, the storyline, the visuals, the acting, the dialogue. These are the generative mechanisms of change that enable critical awareness and the envisioning of new possibilities for how providers can transform their care practices and patterns of relating. And this is echoed by Johnny Saldana, who's a qualitative researcher and performance scholar, who argues that effective research-based dramas, and I would argue really all arts-based initiatives, must have both artistic rigor and be a truthful text. So I'm not going to go in much greater detail about these initiatives here, but I will say that participating in these kind of evaluations made me think about how I can use these methods to translate my own research to improve the quality of care for older LGBTQ people. So together with two colleagues, I'm involved in an arts-based research project that we call Out of Home. So all three of us have done research in our community activism with LGBTQ adults. And it's been our findings regarding the persistence of stigma and discrimination in the context of older adults that has motivated us to get some funding from CHR for knowledge translation. So specifically, we're developing a short film and a public awareness campaign around that film to enhance the knowledge of home care, the home care needs and experiences of older LGBTQ people and the capacity of care providers to do this, to support this population. So I don't have the film to share with you as of yet, because we're just going to start filming at the end of next month. So it's a bit delayed. But I thought you might find it useful to hear a little bit about our process so far, and 3 suggestions or tips that may help you if you decide to integrate arts-based methods or knowledge translation into your own work. So these are my 3 tips. So the first tip may sound a bit obvious, but you'd be surprised at how little this actually happens in practice. So you have to involve your target audience in the development process. And for me, there was a big shift because my target audience is actually not the audience that I do research with. So my target audience is the home care providers who are caring for older LGBTQ adults. So the individuals and communities that you want to make an impact on are the experts of their experiences. They can best advise you as to what they want in terms of education, and they can also act as change makers or champions once your initiative is ready for distribution. So involvement of these experts can be sustained or ongoing and consultative. And so in our case, what we did is we began by identifying a local home care company that is already trying to educate its providers around the needs of LGBTQ people. And we've met with them to talk about their experiences and needs in that area. They agreed to partner with us in developing the video, and we've been having regular meetings to narrow in the focus of the video, get ideas for the kind of messages they want to incorporate in the script, etc. We also consulted with another organization called the Rainbow Health Ontario, which is a provincial knowledge and exchange program that works to improve the health and well-being of LGBTQ people in Ontario and across Canada. And if you're not familiar with their work, they also do in-person training with care providers and organizations and develop educational materials. So having the support of these two organizations enables us to understand what is currently offered in terms of education to home care providers, and much of this I already shared with you, and identify key messages for the video, including scenarios that home care providers typically struggle with. So as just one example of this, our discussions have resulted in us deciding to create two separate storylines for the video, where one will focus on the experiences of cisgendered LGBTQ people, and one on the experiences of trans older adults, and the recognition those are separate stories. My second tip is making sure that the arts-based initiative is grounded in research and a solid understanding of the specific practice context that you would like to change. Care providers in particular are an audience that is oriented towards empiricism, and research suggests that they're more receptive to arts-based initiatives if they know that these are based on research in that area. But this doesn't mean only doing a research study or just reading academic types of publication. So as I've already shared with you, it involves learning directly from the experiences of those communities that you would like to impact. So in doing this kind of research, we were able to identify that there really are no education and training materials on LGBTQ people that are specific to home care in Canada. And we also identified features of existing videos and other types of education that may be less than effective and we would like to change. So most training is much too generic in content. It's not racially or gender diverse. It's very heavy on terms and numbers, and it's lacking in practical examples of interactions that are actually relevant to home care. So there's many videos such as the healthcare video that I showed you in the beginning, and much of what those participants are talking about is actually not relevant to the kind of interactions that happen in home care. So my last tip for creating arts-based initiatives is that aesthetics matter as much as the research. Creating a research-based film or animation does not involve a linear translation or replicating academic texts. This is a creative process of reinterpretation of the research data, along with the use of theatricality and other artistic practices and techniques. To paraphrase Saldana again, this kind of work requires a shift away from thinking like a social scientist to thinking like an artist. And while there's many ways of doing this, the typical process for me has involved crafting composite characters, emphasizing multiple tellings of the same event, workshopping scenarios, dialogues, props, and sound, all to achieve a balance between realism, that is actual events and experiences from the data, and dramatic reinterpretation and cultural critique. You want to create a film or an arts-based knowledge translation that is engaging and believable and draws the viewer in. However, change in practice requires more than telling a good story, because you want to shift your audience from empathy and awareness to identification and action. So creating an aesthetically bad film or animation that is confusing or not effective in prompting that shift would actually be worse than not creating a film at all. And researchers are trained in how to present a good story on paper. Artists and designers are trained in how to present that good story on stage or on screen. So you need both types of persons to create an effective arts-based initiative. So for this reason, in our case, we've partnered with a professional media and design company who's helping us to develop the storyline, the script, decide on actors and the sound, the visual, and really put it all together into a film and a public awareness campaign. And of course, this was really made possible because we have funding from CHR to actually do that. So in summary, older LGBTQ people seeking home care face deeply entrenched stigma, as well as providers ignorant of the specificities of their lives and experiences. There's thus a critical need to enhance providers' competency to provide affirming and respectful care to this population. And arts-based knowledge translation initiatives such as film or animation are particularly effective for stigma reduction and to effect change. And my hope is that our initiative out at home will make a tangible impact in that regard. Thank you very much for your attention. I look forward to your comments and questions.
Thank you. Comments, thoughts, questions?
Just in terms of your art-based methodology, kind of, I think what you noted is really key in the sense that it has to be done well. And I think that there are plenty of initiatives. I don't think not specifically around LGBTQ older adults, but in general around older adults that are done. They're not done effectively or not done in a way that actually can be penetrated in the community. And I think that's really key, something to take into account, especially with humanities-based research, but also social sciences. So I don't know if you could suggest maybe a paper. Is there maybe like an article you have or you know of?
I mean, I can suggest all the papers that I've written.
Okay, yeah,
There's
perfect.
some examples of that. But yeah, I can certainly send any like more examples of that to you. But so Johnny Saldana, the person that I mentioned, is somebody who's written a lot about creating. So he's mostly created research-based dramas, but he's created almost like primers for how to do that really well, books, articles, etc. And so it's a really great person to start with. And anything that they write about is great to take for other kinds of arts-based initiatives. I think the key is to realize that arts-based knowledge translation is a ginormous field, of which research-based arts knowledge translation is one small component. There's many that are not research-based, and so all the stuff that I've talked about is specifically research-based.
Just kind of building on Stephanie's question, maybe a bit about the process you go through, like when you're selecting your partners or this sort of thing. Like, do you go to a number of different companies and reviewing their work? Like, how do you know that the work that might is produced, especially if they haven't done anything in your field, let's say, might be a good product? So I don't know if you have any thoughts on that.
Definitely. I think that the whole team really matters in terms of how you work together. And that is true for the artists on your team, as well as for the scientists, as well as the community members. So we were pretty lucky in our team, I think. So first, in terms of finding a good media company, we actually pitched our project to different companies.
Okay.
And this was the second company that we pitched to, and we had a really bad experience with the first, mostly just because they weren't engaged. And so I think it really matters. You need somebody who will be really engaged with you and willing to work with you, and it's a very lengthy process. And the same happened with the community organizations as well, is that we did the research to figure out who could be a potential person to approach, and then actually approached them and pitched it to them. But it all requires a lot of work, a lot of really groundwork before you start working on the project. So I can't imagine doing something so labor intensive and so collaborative without having a team of people that you actually like working with.
Yeah.
That's actually something that I think Marlene Goldman kind of brought up in her seminar. So she was the first one, I think, of our seminar series. I don't know if you've heard of her work. So she kind of, we filmed, I don't remember the title of her video, but it was based on Alice Munro's kind of
Barely
time slips or something. Yes, something. And it was really, really interesting. But she also kind of touched upon how, you know, she was also the writer, like the screenwriter, but also the director, and she was kind of the first person. It was her first time walking onto, let's say, a set, and also having the, as a researcher, as kind of an academic, she kind of felt that it was harder for her to kind of command attention and also command the room, to kind of have her direction and, you know, want to follow that direction, because as you said, I think it's very different arts-based research and kind of in general arts-based method.
Definitely. And there's many models for what works for you. So I think, because in my experience up until this project has always been the capacity of a researcher who works with artists to then create something. That's really a model I'm very comfortable with. I understand that I'm primarily a researcher, not an artist. And so I would like to collect people who are primarily artists, not researchers. But you got to be willing to move both, like on both ends. And I think there's other models that may work for you, better for you than others. right? For some people, like one person that I worked with, Julia Grace, so she's somebody who's both an artist and a researcher. And so for her, it works to do all aspects of that. It may not necessarily work for you or for me.
I'm always the kind of person who always says, let the expert do what they're good at. Like there's no point in, do what you do and do it well. And that's the kind of thing.
It's true, but there's layers to it. Like I could probably do digital stories on my own, but I would not create like a film with a script, the sound, the visual on my own.
I recently, I'm writing a paper at the moment on posthumanism and gerontology. I recently cited one of your papers. So I'm interested to know if I got it right.
Which paper?
And, well, I was reading about, I think it was probably the work I did with Julia. But I'm interested to know what you think about the way that arts-based methods, particularly knowledge translation, the way it works on two levels simultaneously. We all know it works on one level cognitively, fully cognitively. It shows messages, it tells stories. But there's another level, I think, in which it works, which is less than fully cognitively, less than fully consciously, and affectively. That it creates, so there's a transhuman, if you like, affective energy that's going on between, in the case of a play, actors and the set, and the audience, right? They're involved in the same. And there's an energy that builds together, and I think that helps interchanges with the meaning that's being conveyed. I think someone like Carol would describe it as instead of identity politics, kind of a coalition of affinity, effective affinity. So I was wondering about, just this, what you think of that relationship in arts-based methods between obviously political storytelling and on another level, the effective processes going on.
I think you're totally right. I think there's two different levels happening here. And in my experience, it is this kind of change or interaction on multiple levels that makes these kinds of research-based art initiatives so effective. It's because there's the really good story, especially if you're able to identify with the characters and feel things, draws you in, and you become part of that story. And often in really good, aesthetically good arts-based initiatives, there's also what Julia calls like creative gaps that let you participate more and fill those in to understand them as you will based on your experience. And so this is happening, and at the same time, so you're learning also cognitively and a particular educational message. But there's something about the arts-based initiative, and often, especially if it has like a dramatic storyline, that also carries you along that storyline and the process, the feeling of that storyline and the effective learning that happens is also really important. So I think you're totally right that there's multiple ways of learning and interaction that happen with it.
I found like, just to follow up on it, so when I'm looking at Cracked, that production you're working on, there's obviously an effective energy when you're watching it, when you're there experiencing it firsthand. But that's kind of like stored in you, in a way. Like, so if you encounter a situation later, those memories, those effective feelings are almost like reawakened, like haunting from the past. You remember the play, right? You remember sitting there, you remember what, So it's not that I don't think arts-based research works in the moment, but those memories, those effective memories are stored within us.
Definitely. And there's actually an arts-based researcher, Kate Rossiter, that has written about this as well, about how much of the evaluation we do is just in a very small component of just immediate interaction with the arts-based initiative, and we're not actually capturing the other kinds of interaction that happen long-term that continue to resonate in you. And
it's like songs, right? They don't go away. You know what it's like to be into that song. It takes us a couple of bars and back into that moment.
Definitely. And that's my hope with this video, is it actually augments the kind of education providers are already receiving in the home care company. But it'll be able to connect it in a different way than they would with the kind of like in-person or paper learning that they're doing.
So this makes me think a little bit about like Netflix documentaries and how they can make massive impact on people's values and cultural shifts toward behaviors. And so there's all this opportunity to change people. And are you interested in quantifying the effect of these things? I know it's hard to do, but if you wanted to do it, you have to start before, right? So sort of measuring values and such. And is that somewhere you are interested in wading into? See what the effect is after you create this thing?
Not necessarily quantified. So I find that generally if you're trying to tackle stigma or influence people's like bias perceptions, that I find quantifying their level of bias or knowledge and attitudes is actually not a really good way of measuring change, because people are really good at answering those kind of questions and providing, like there's many scales for measuring attitudes towards sexual diversity. And the problem is people know what to answer. And actually knowing what they scale, like what they will rate on that scale is actually doesn't tell you much of what happens in the context of an interaction with a person. So I'm not so much interested in contributing to that literature because I don't find it a very good evaluation. But what I am interested in is measuring, is evaluating the impact of these kind of arts-based initiatives. And some of the stuff that I have done included a baseline evaluation, as well as evaluation right after watching the arts-based initiative and longer term. And doing this in a qualitative way, you can actually capture both people's perceptions prior to watching it and after. Because people will share with you with how they've engaged with it and how engaging with it has made them shift from a previous understanding or belief to a different one. Is that it?
Yeah, that's a really interesting research.
If you think of any questions afterwards, please reach out.
Absolutely, yes. And thank you so much for coming out.